Today we're going to talk about facial pain and headaches. It's a big topic, so it's very hard to put it in 60 minutes. So it's going to be more like an overview. So if you have any questions about treatments or more details, I can answer them after the lecture. So first we'll start with definition of the headache. So we define a headache as a pain in the head located above the eyes and ears and behind in the head on the occipital regions, and sometimes also the upper part of the neck. So basically everything up here is defined as a headache. Everything below is if patient complains of pain in these areas, you'll call it facial pain, basically. It's very important to differentiate that because then it will be easier for you to make a diagnosis just by localization. So when we have a patient with a headache, we always have to think about secondary causes. So we divide headaches in two groups. We divide them in primary headache disorders, which are supposed to be benign with no findings on MRIs or imaging studies, and the secondary headaches, which you can have findings on imaging studies for these patients. Now, I'm going to talk about primary headaches primarily here because it's the most important topic, and majority of patients you see in the clinics who present with the headaches have usually benign headache conditions, which include migraines and tension headaches. So we'll talk about classification, which is the biggest tool we have developed to categorize the headaches, a little bit of pathophysiology, differential diagnosis, and current pharmacotherapy. So today we're not going to talk about psychological therapies, but it's also very important to implement these modalities in the treatment of headaches. Now, the most frequent headache is tension type headache, and this is the Danish population data from 1991. 74% complained of tension type headache, 10% of migraine, and 0.14% is cluster headaches. The numbers in US are pretty much similar. It's anywhere from 8 to 15%, more females than males. And despite this fact that the tension type headache is the largest group, we don't see them much in the headache clinics or in neurology clinics. Now, primary care physician and internal medicine physician might see them more than us. Now, do you know why the reason is we don't see them much, the tension type headache patients?
So by the time you see them, it's gone.
Yeah, it's basically because it's also mild headache, and people just don't bother to go to the physician. It's they just buy the over-the-counter analgesics and they don't come and see. But in fact, if you look at epidemiological data, is that the cumulative number of disability days and the socioeconomic impact of the tension type headache sometimes can be larger than a migraine. So it kind of remains a slightly undertreated group, and unfortunately in US we don't see this group until they get sometimes migraine later, or they get like medication overuse or chronic tension type headache where they have to see a physician. In the countries with socialized medicine, like European countries where I practice in Denmark, you see them more because the access to physician is easier, and I was able actually to do research on this group of people in the past. Now, these are very important slides because it shows the criteria for migraine. Basically, if you have a patient and you want to make a diagnosis of migraine, it's based on, it's like a syndrome, it's based on certain criteria. So first, you need to have a headache which has been there at least 5 times, 5 episodes, lasting from anywhere from 4 to 72 hours. And then you need to have at least 2 of those characteristics. It could be unilateral, pulsating quality, it could be moderate to severe intensity, or aggravated by routine activities. Now, you can still have bilateral headache with migraines, but you can have, it can still be migraine because it's pulsating and it's severe. So anytime you see severe headache, always think of migraine, because tension type headache is usually mild or moderate. So, and you need at least one of these following criteria, which is nausea, vomiting, or photophobia or phonophobia. Now, you can see sometimes patients fulfilling this criteria, but not this. And it happens especially in the beginning when, for the first time, the person develops a migraine. He can miss some of the features. I never knew about my migraines. I thought I had always had tension headaches. I was a medical student until my brother injected me with nitroglycerin as a part of research project, and I developed full-blown migraine headache that day. So now I know I have migraine, and it's actually not that severe. It's mild, but it has unilateral location. It's aggravated by physical activity. So I rarely have this criteria. Like once a year, I will get like severe photophobia or phonophobia. Now, when we talk about migraine, we always think of pain, right? We always think of pain in the head. You know, this is the first thing. You call for a consult to treat the pain, but migraine is more than a pain. It's actually it's a complex condition. Now, first of all, if you think of an individual having a threshold for his headache or migraine, then you need to have certain triggers for that. That could be stress, you know, or just walking in the mall and see a lot of people. Any stimuli can actually aggravate migraine, and anything that can trigger the episode or pass this threshold. Then a lot of migraineurs would complain of some symptoms hours or sometimes days before their headache. It could be hunger, you know, yawning, sometimes mental changes like, you know, feeling depressed or sometimes even feeling high. So there's we have never studied this, so we just started to explore it more because of it's probably related to pathophysiology of migraine, and maybe if you have to localize to the brain, it could be somewhere in hypothalamus, some areas which could be involved in this, you know, in the development of the symptoms. Then some of the migraineurs would have aura symptoms, which I'll you know, comment later on. It could be visual, sensory, or speech disturbances, lasting, you know, a few minutes, up to 1 hour, followed by the headache phase. This is the phase which we treat, which we concentrate on, which is the pain phase. And then there is an improvement phase, which is similar to premonitory. People can have sometimes feeling that they are disoriented, you know, feeling tired. Like a lot of patients will tell you, like, I feel like a little bit loopy after the migraine. I don't know what to do. Like, and I cannot work if I'm at work. And then there's an end of attack. So as I mentioned before, we divide migraine with and without aura. And 2/3 of migraineurs are without aura, which is called common migraine. And this is a classic migraine. These two conditions, they can actually coexist in 5% of individuals. Now, in order to have migraine with aura, you need to have reversible either visual symptoms, flashing lights, you know, zigzag lines, sometimes loss of vision, or sometimes the sensory symptoms, which are pins and needle paresthesias. And if, like the Giorno, which we think he has a patient who has basically speech disturbances, which we don't know if they're related to migraine or not, but they can have that. And usually they have to be unilateral, and they have to develop within over the 5 minutes and no more than 60 minutes. If they have more than 60 minutes, they can still have migraine. I would suggest to consider to treat them like to rule out stroke patient until you have ruled it out and, you know, you establish this pattern in this patient, and you can feel safe to you know, to call it migraine with aura. This is a description by physicians in 1870. He described his own auras, and that's what they usually will tell you. It starts like a little spot, and it, you know, becomes bigger and bigger, and at the end it's full zigzag lines, which is also called fortification spectrum. And this is quite one of those auras they can describe. Sometimes what you see is they will tell you at the same time they develop this visual disturbances, they will have some numbness and tingling sensation in their fingers, and slowly this numbness gradually increases and also moves up. And this correlates with pathophysiology, which I'll show you later how. Now, this is a classical presentation in 90% of people. Up to 60 minutes aura, 5 to 60 minutes, and then free interval, which could be like 2 minutes or so, and then followed by the headache phase. But this is not only this is not the case for some of the patients. For 4%, you can see aura sometimes overlap with the headache phase. or it can actually occur during the headache in some people, especially with chronic migraineurs, when they have all the time the headache, and and they get exacerbations, which are more like a migraine headaches, and there in the middle of that attack, they can have aura symptoms. And in very minor group, you can have auras without the headache phase, which is included in classification. And this is a situation where you see them in the emergency room and you rule out a stroke, and then it's kind of diagnosis of exclusion. Now, the pathophysiology is complex. There's still debate about the pathophysiology. We don't know for sure what the initial event is in migraine. We don't know if it starts in the vessels, in the brainstem, or in the cortex. We know that some changes are ongoing during the headache attack. We know that there is a dilatation of the vessels, both venous and arterial vessels. And when there's a dilatation, there is a leak of substances which irritate the nerve endings, and then the nociceptive processing starts. So it goes all the way to the trigeminal spinal nucleus, where there is the upregulation of the second-order neurons, and there the information is conveyed to the thalamus, and from thalamus to the cortex. Now, some studies have shown, and some neurologists believe that the initial event is in the brainstem. They consider migraine as the brainstem disorders. The other groups think it's more like a trigeminal vascular condition. It starts in the vessels, and it activates the nociceptive system. And another group, which is from Harvard, Massachusetts, they believe that it starts in the cortex with the cortical spreading depression and activates the pain pathways. As again, if you believe in cortical spreading depression, so cortical spreading depression is a very interesting phenomenon. It's been shown for the first time in Denmark by my supervisor in '87, who described depolarization of neurons starting in the occipital region and spreading towards the sensory areas. And this actually correlates with the aura symptoms. This has been described in patients with aura primarily. What happens is an increased metabolic demand, there are flow changes, and you see those sensory phenomena. And the Danish group also believes that initial event is actually around the vessel. So as I mentioned before, there's a dilatation. There is a release of CGRP, which is a new substance, and actually there's a new drug on the way to treat the migraine, which is CGRP antagonist, and which is going to basically block the receptors here, and maybe on the axons as well, and which causes this activation causes a central sensitization, which is activation of the second order neuron. And patients with migraine will tell you about sensitivity of their skin to touch, which is the cutaneous allodynia, a marker of central sensitization. So we do have some of the evidence from the experimental studies, and we think it is mainly the cause. Now, the tension type headache is totally different in terms of pathophysiology. Initially, we thought it was the muscular headache. It was developed because of the muscle tension, but we had kind of moved away from that kind of explanation. And indeed, actually, if you push on some of the points here, what's called trigger points, you can actually develop the migraine headache. The tension headache, which is kind of mimicking totally the tension headache. However, when the studies are negative, now we think the muscular factors are more like a phenomenon for tension headache. But still treating them would be an option, because we know that the increased tension in the muscles can make the headache worse. So again, if you have a patient with a tension headache, you will still treat the muscular factors, despite the fact they are epiphenomenon. They're not involved in development or pathophysiology of it. Okay. Now, the tension type headache is defined as bilateral, pressing, mild to moderate, and can be with and without muscular factors. And the chronic, the way you differentiate a frequent episodic tension type headache or episodic tension type chronic is by the number of days, which is you need to have 15 or more days with a headache per month. And here, what we know is that we think that the initial event is in the muscles, around the vessels in the muscles, because there are nociceptors around the vessels in the muscles. There is a basic activation of this first order neuron, which causes the synthesization of the second order neuron. And here the nitric oxide has been shown to be mediator, actually. And the reason we show, and we believe it is, that we published a study in Lancet which showed by using the nitric oxide inhibitor, we actually reduced the number of headache days in patients with chronic tension type headaches. So we have some proofs on that, and also some animal data also with animal models showing that. Now another third headache, which I showed you in epidemiology, less common is cluster headache. It's a more dramatic headache, and a lot of people get scared when they see the patient with a cluster headache. It's usually defined as 5 attacks of unilateral retroorbital pain, but they can also have sometimes temporal or parietal areas involved, lasting anywhere from 15 to 180 minutes, and occurring anywhere from 1 to 8 attacks per day. You need to have this description, and also you need to have one of these criteria. So one of these criteria would define the patients having a cluster headache. Now, most of the time you see basically red eyes and lacrimation or nasal congestions. But a lot of times if the patient comes and tells you that I'm restless and agitated during the attack, which is not the case for migraineurs. They usually want to be in the bed, dark, quiet room. So these people actually, they pace, and sometimes they even too restless and bang their heads to the walls and get actually relief from that. This is a very significant diagnosis, and it's very important to diagnose these patients because it's associated a lot of suicidality. So, it's very important to treat these patients if you see them. This is a real patient from the Danish Headache Center who developed a cluster headache attack, and the picture was taken, and you can see he has some ptosis, conjunctival injection, right, and some lacrimation. Now, the reason we call them cluster headaches is because they occur in clusters, basically. There's some seasonal variation too. Some people it's in the spring. Sometimes people get it in the spring, sometimes in the fall. And you'll see here, they will get a cluster of headaches, and then there's a remission period, which is usually more than 1 month. Now, if this period is shorter, then we call it chronic cluster headache, which is more severe, challenging condition, and but very, very, very infrequent compared to the episodic one. Now, these are the less frequent headaches, which good to know about because they're in the spectrum with the cluster headache, and we call them trigeminal autonomic cephalgias. I see them in a headache clinic because they usually are referred and they're never really diagnosed by others. And these are the headaches where you need to really think about secondary etiologies like malformations, tumors, because they can mimic those kind of headaches. Now, the only difference between them and cluster headaches is is actually the minutes. Now, you can see here if you have a SUNCT, which is short-lasting unilateral neurologiform headache attacks with all those symptoms which you can have during the cluster headaches. Difference is they can last anywhere from 5 to 40 seconds, and they can have, of those episodes, anywhere from 3 to 200 per day. It's very devastating, very challenging to treat if people come with this. Paroxysmal hemicrania, pretty much similar to SUNCT. The only difference is it lasts anywhere from 2 to 30 minutes. Now, cluster headaches is 30 minutes to 180 minutes. You remember the previous slide? So we believe it's kind of condition. These conditions are in a spectrum, and they might have some different pathophysiologies, but most of the treatment modalities are the same. And then we have the hemicrania continua, which was initially believed to be trigeminal autonomic cephalgia, but now we put it as a different condition in the classification. It's basically unilateral, continuous daily pain with intermittent symptoms lasting anywhere from 10 to 30 minutes, and described as paroxysmal hemicrania, basically. Now, this is the also important slide because this helps us to differentiate two most common headaches. Now, if you have a patient in the clinic and you don't know if the patient has a tension-type headache or migraine, then this would be the good slide to use because it shows us what differences are. Now, The female and male ratio is pretty much the same in both conditions. Age of onset can also be similar, but migraine nurse usually have aura. Tension type headache patients never has the aura. Now, if you have a patient who has symptoms of tension type headache, maybe you're not sure if it's migraine, but has an aura, most likely it's a migraine, which has not been fully developed in the full-blown migraine, basically, in terms of its features. And also migraine have the associated features, which is photophobia, nausea, vomiting, not common for tension type headache. And if it's pulsating, it's more like kind of vascular kind of migraine-like headache and not a tension headache. Okay. Now the treatment is different from country to country. Now, if you are in a well-developed industrialized countries, you have access to triptans. You will use them first. But if you are in some third world countries, and then you will use maybe like aspirin and metoclopramide. If you want to be cost-effective and if you want to practice the evidence-based medicine, then usually it's better to start with the simple analgesics if they help. You will just use them and then slowly move to non-steroidals if they don't help, and then triptans. Now, I didn't put ergotamines and here because they've been used before, and now since we have triptans, I've never prescribed ergotamine for patients. Maybe a few patients who do not respond to anything, I'll prescribe them DHE nasal spray, but that's pretty much it. Most of the time, I use the triptans or the simple analgesics or non-steroidals. Now, the possible sites of action of triptans, again, we believe it works three places. One is on the venous, perivascular, on the neurons, basically, around the veins, and also on the arterial vessels, and as well as in the brainstem. Now, triptans has been really a revolution in migraine treatment. They were introduced in the beginning of the 90s, and when they were introduced, it's basically boosted the research, and patients were really satisfied with the treatments. Now, the efficacy is anywhere from 60 to 80%. It's pretty high for a treatment. And there are very few side effects. The only disadvantage is the headache recurs in 20 to 40% of the time, but you can still use a second dose of triptans when you prescribe it. Unfortunately, there are some cardiovascular diseases which are contraindication of triptans, and studies have been shown if you use too many triptans, you can actually have arterial hypertension. And of course, the price. A lot of times you have a hard time prescribing them because the insurance companies would not approve the medication because of the price. But now, since they've been on the market for 10 years and some of the patents have been running out, so they're going to become more available for the population. Now, the preventive treatment of migraine includes various medications. We don't have a migraine-specific preventive medication. So everything we use is either antihypertensive, antiepileptics, calcium channel blockers, or TCAs. The most widely used medication in Europe and US is a beta blockers, propranolol, and also topiramate. Like if you go back 10 years to nortriptyline and amitriptyline we use mostly, I still use them a lot to TCAs. These are the medication with the highest evidence. Now, the anti-serotonin drug is not available in US, unfortunately, only in Canada and Europe, and so is flunarizine, which is not available in US. But all others are available and can be tried in patients. And also, the tolfenamic acid is not available as well in US. Now, the therapy of tension type headache is different from migraine. And again, that's why it's very important to differentiate tension type headache from migraine. Now, here we use, basically, triptans are not effective for tension headache. So you usually use non-steroidals, analgesics, or combination drugs. Now, for preventive therapies, is there a pointer here? Is it a pointer? Yeah. For combination therapies, you use usually amitriptyline, which has been shown to be the most effective drug. And the role of Botox has been negative studies in chronic tension type headache. and muscle relaxants, it's controversial. SSRIs are usually not effective. Now, I didn't mention Botox for migraine. There is a recent study in chronic migraine that Botox has been shown to be effective by reduction of days by 9 days. But there was also a very high placebo response in that study, so we're not sure if it was fully effective. Now, for cluster headaches, again, we also, like with the migraine, we divide in an abortive therapy and preventive therapy. Now, the drug of choice for cluster headache is basically injection of Imitrex. It's like a miracle. I mean, the patient comes to you, and I remember I have one of my patients that was actually in the office with me, and she was having the cluster headache attack. And it was actually continuous. She was having it for 40 days. Nobody was treating her. It was very devastating for her until she saw me. And I had it in Imitrex injections. So I gave it to her. And she told me afterwards that at this moment, she told me she could just compare me to God. Which was kind of funny to hear, but it's really a big relief. So you inject it once, and within 15 minutes, 74% will have some relief, reduction of pain, and 36% will have full pain relief in 10 minutes. And this is compared to placebo. So another way to treat the cluster headaches is with oxygen. Yeah, anywhere from 6 to 7 liters per minute for 15 minutes. You give them oxygen, and it helps. Air inhalation reduces by 7%, which is interesting. If you ask the patient with a cluster headache what they do their attack, they will tell you, like, it usually occurs at night. So what they'll do, they'll go to the window, open the window, get a fresh air, and they'll get better because they'll get more oxygen. Now, preventive therapies, there's a short-term prevention and long-term prevention. Short-term prevention is used when the patient is in your office, has never been seen by a physician, is in a cluster headache period. So what you will do, you will give them usually steroids. That's what I usually do, to overlap start of the treatment with verapamil, which is the drug of choice for cluster headache. So patient comes, I have a cluster headache doctor, it's 8 attacks per day. So what I do, you give them sumatriptan injections prescription, you give them prescription for verapamil, and then you give them prescription for taper of prednisone for a week. And the headache will respond significantly most of the time. I mean, again, you can have a patient with cluster headache which is not responding to verapamil, then you will have to use lithium, or methyl sergite is not available in US. You can only order it from the specialty as a compound from some pharmacies in US still. You can use valproic acid, topiramate, or gabapentin, but they're less effective. The verapamil is a drug of choice. And the major mistake done by a lot of physicians and neurologists is not pushing the dose up, because they usually stop on 240, and that's it. Sometimes you have to go to 480 or even higher. But again, when you prescribe that, you need to, with verapamil, there's recent studies that have been shown, you need to do weekly EKGs to make sure that they don't develop the first degree block, or any arrhythmias. Now, when I mentioned to you the first slide, so you didn't see that. First slide showed that we divide headaches in primary and secondary headaches. And again, I mean, even you guys, I mean, I've seen sometimes Dr. GC's patients, and I started to question diagnosis of migraine in some of them. So it's very important to be on alert when you see patients with a headache, even if they're sent to you for the pain management, just for the pain management. You need to see the secondary causes. You need to think about the secondary causes, right? So this has been developed by Brian Grossberg from Montefiore Headache Center. So he told me that if you go to emergency room to do a consult for a headache patient, just if you think of this, you might actually cover all diagnoses, possible diagnoses. Now, cerebral venous thrombosis, acute strokes, hemorrhagic, mass lesions, pseudotumor cerebri, it's like an epidemic in the US now. Because of the overweight and obesity. Pituitary hypoxia is a very serious condition. You need to have, need to be alert on this, especially in pregnant population. Meningitis is, of course, a lot of comorbidity, high morbidity. Acute closure glaucoma, temporal arteritis, dissections, hypertensive encephalopathy, subarachnoid hemorrhage encephalitis. Now, and this is very important because those conditions, they can mimic migraine. I mean, you can have a patient with just migraine headache and they can have totally different diagnosis. Because again, migraine headache is just a headache. It's activation of nociceptors, certain areas of the brain. And those conditions, they can trigger those areas and and activate them independently of migraine mechanisms. Now, in 1951, Peters and Horton, they actually described this phenomenon at Mayo Clinic. When they saw people who were using the ergotamine for their migraines, they started having more frequent migraines actually, which is paradoxical. And this observation led to actually another study we did in late 50s, where studies were done on like few patients, but still it's significant studies because now we have this condition is in classification, where they actually have shown that when you do the withdrawal of ergotamine in the patients, they actually get better. Now, and later when later studies were done on simple analgesics in the 80s, and when triptans were introduced in the 90s, they did in triptans, they showed that if the individuals overused acute medications more than 10 days per month, they were at risk for development of medication overuse headache, which has features of migraine or tension-type headache, very resistant to drug therapies, and a huge problem. And approximately 50% of patients in U.S. headache clinics, and anywhere from 15 to 50% in other European headache clinics, patients present with this condition. And that's what we see basically with most of the patients. Even we call them migraine, we call them tension headaches, in our diagnosis, but they do have this probable medication overuse headache, which needs to be treated. Now again, going back to the red flags of the headache, it's very important again to differentiate from primary to secondary. And David Dodick from Arizona, Mayo Clinic in Arizona, he developed some mnemonics and some to kind of help us to differentiate secondary from primary headaches. And again, if you have a patient who has headache onset after age of 40 or 50, you need to be on alert. I mean, you can still have a migraine headache after age of 50, but it's not that frequent, and that's why you need to think of tumors or other secondary etiologies. Changing in the headache pattern. The patient tells you, my headache is a little bit different. I think it's not like the same. That indicates it might be a secondary etiology. You need to get an imaging studies and some labs. Now, if it's progressive, it's more frequent. Started to become frequent over the past 10 days or 20 days. Some provocative factors like cough, Valsalva maneuvers, sexual intercourse. All this kind of red flags need to be addressed with the imaging studies. Another way, look at the associated features. If they have vomiting, which is persistent, progressive, they have fevers. Basically, you will definitely, I mean, just having those symptoms, you will definitely rule out some other causes, right? Infections, you will see them. And you will be reluctant to call them as migraine headaches. And this is the SNOOP. This is the famous mnemonic, basically. Systemic symptoms, neurologic symptoms, sudden onset of the age of 40, and prior history of headache, which is different. And the new headache is more progressive. Now the facial pain, right? So we still have some time. Okay, because lecture was on headache and facial pain, so I'm going to mention a little bit on the facial pains also. Now there are three most common facial neurologies which you need to know. One is trigeminal neuralgia, very important diagnosis. Glossopharyngeal neuralgia is also important but less frequent. So it's a very rare condition, and postherpetic neuralgia, we see them sometimes as well. Now, when I mentioned you about cluster headache and trigeminal autonomic cephalgias, even they're under the headache category, but sometimes pain can be perceived as in the face too, because even if it's by definition it's retroorbital pain, but sometimes it can be radiating to the face, so they can sometimes present with the facial like pain and see dentists for it and all these things, the cluster headache patients. So that's why in differential diagnosis of the facial pain, you need to consider cluster headache and other trigeminal autonomic cephalgias. And this is a typical facial pain. The patient we injected with Botox a few days ago, which she has. So let me see. It's probably the same, right? Right. Okay. Now when you make a diagnosis of pain, and for pain fellows, this is what they do every day, is this, you first describe the pain, you localize, you want to know what quality it is, intensity, duration, and if it's aggravated by anything, activities or any other triggers, or any other associated symptoms, right? You want to know if there are some autonomic symptoms, there are some trigger points, there's some photophobia, nausea. If you answer all these questions, you can actually make a diagnosis for most of the visual pains and headaches. Now, neuropathic pains it's interesting pains. Its stimulus can be stimulus independent and can be stimulus dependent, meaning that if it's stimulus independent, that means that you can have spontaneous pain, right? So without any stimulation, or it can be stimulated by, for example, light touch, or sometimes the pinprick stimulation, like when you do that in an examination. So now, what is trigeminal neuralgia? This is from International Headache Classification. So it's a headache which is usually lasts anywhere from a few seconds to less than 2 minutes, and it has at least 4 of the following criteria. So distribution is usually unilateral. It's along the trigeminal nerve. It's sudden shooting electric shock-like pains. It can be a very severe excruciating intensity, and it can also be basically provoked by certain activities such as like eating, talking, or any stimulation, brushing teeth, and all those things. And it usually comes like paroxysms of pain, and usually they are asymptomatic in between. But you will see sometimes, which we call as trigeminal neuropathy, and that's what we debated the other day. I know Harlan is here. But then you will still, sometimes the patients with trigeminal neuralgia will still complain of background pain in their face because of activation of their neurons. They'll still have this kind of dull sensation. And on top of it, they can develop those severe excruciating pains. Now, localization, usually it's in V2 and V3 distribution. Rarely it's in the V1 distribution. And rarely it's bilateral. So most of the time it's a unilateral pain. And in very few cases, like 10 to 50%, it's on all 3 divisions of the trigeminal nerve. Now, the usual duration is not 2 minutes, usually less than 30 seconds. And it's, again, there are some triggers. And it can be, as I mentioned before, it could be dull pain, diurnal pain all the time. It's pretty much repetition. Now, it's interestingly, even if you see it a lot in the pain clinics, it's actually not that frequent. It's only 108 men in 1 million, or 200 women in 1 million develop that. So annual incidence is anywhere from 3.4 to 5.9, and it's usually conditioned in the elderly population. The mean age is 67 years. Now, what is the etiology and pathophysiology of trigeminal neuralgia? It could be sort of idiopathic because you can't find the cause. It's just there, and you treat it. But it could also be due to the oral disease, chronic oral disease, or acoustic neuronoma. Sorry about this. Or a MS plaque. So if you have a young individual who comes to you with, who is like in 30s or 20s, comes with trigeminal neuralgia symptoms, you need to think of MS. So it's very important. It's like a board question, sort of. Sometimes what you see is what neurosurgeons usually concentrate about is there is some arterial loop putting a pressure on trigeminal nerve. And then what you can do is you can decompress that and surgically and give the patient relief. AV malformations in that area. This is superior cerebellar artery, and you can see if there's an aneurysm there, it can put pressure on the nerve. There's a trigeminal ganglion here, and can cause that as well. Epidermoid cyst is a rare tumor which can also usually comes in this location, and can cause the trigeminal neuralgia as well. So always think of secondary etiologies. So if the patient comes with the trigeminal neuralgia, you will definitely do the imaging studies to rule out the secondary causes. Now, what happens is, pathophysiologically, what happens, why this pain comes is there is a local irritation which causes the spontaneous ectopic impulses in the axon, and it results in it conveys the information to germinal nucleus, which is short, high-frequency barrage of impulses. Then the information conveyed from the thalamus to the cortex, and then you perceive it as a pain. Now, when you need to order an MRI, when it's rapidly progressive, severe trigeminal neuralgia, there is sensory symptoms like numbness or, which you might think this could be some MS. I mean, again, MS is a condition which occurs in young, but it also can occur in older individuals. So, and if the patients are younger than 50, you would order the MRI. Now, guidelines for the treatment. First, you get a history and examination, and then MRI if necessary, and then a medical management. The drug of choice is carbamazepine or Tegretol, then you will think if it doesn't help, you can use Trileptal or lamotrigine, baclofen, gabapentin, valproic acid has also been used. Let me just see. Sorry. Now, if you cannot manage medically, then you need to have surgical treatment or interventional treatment has been there. Now, the surgical treatment, what you can do the radiofrequency thermocoagulation, or what can you do? We do it actually in PAC. Sometimes Dr. G can do that. I know you guys have assisted her in those procedures, where she can inject, the ganglion, trigeminal ganglion, with the glycerol injections. And this is the posterior fossa surgery with microvascular decompression. Now, the next few slides talk about some advantages and disadvantages of the procedures. We'll see. And you can see here, so what is the difference between the glycerol injections and radiofrequency thermocoagulation? Generally, based on the slides and also in the studies, you can see glycerol injections are less associated with less side effects and better preferred, they're both easy procedures, but of course the efficacy of radiofrequency thermocoagulation is better than glycerol, but the side effects wise, glycerol is better. So it's up to the surgeon and also clinical situation to decide which one to do. And this is a very, very serious complication of the surgery of thermocoagulation, radiofrequency, which is anesthesia dolorosa. I've seen a couple of patients. It's basically the pain gets worse and it's refractory, and you cannot basically do anything about it. It's just they're on very high dose of opioids. Sometimes you can control the pain, but it's very hard. Now this is the decompression. I showed you how to do it. The recurrence rates usually in 2 years is 72%, which is quite high, but still it's a good option. Now let me just see. We'll go over. Now again, when you have a drug therapy, this is again another slide showing how would you think about. Would you schedule the patient for a surgery? Would you send the patient for the surgery? Now you do first a drug therapy. Be more conservative. Try to do drugs first, and if they don't help, then you'll think of surgery. And if it's medically unfit patient and they are less than 65 years old, it's always posterior fossa surgery is an indication. And for elderly and medically unfit patients, the peripheral surgery or surgery at the level of posterior ganglion, less invasive than this, is better. Now, glossopharyngeal neuralgia, again, it's very rare, and we can see it's pretty much the same quality as trigeminal neuralgia. The only localization is in the posterior part of the tongue, tonsillar fossa, pharynx, and in the lower jaw, and sometimes in the ears, because it basically follows the old innervation by glossopharyngeal nerve. It's sharp stabbing and severe pain, and it can be precipitated by eating, talking, and it's very dramatic too. I mean, if you see the patient, they're like coughing and having the pain, and they're stopping, and what you do is basically, this is how it happens. What you do is that Let me just see. You can actually decompress sometimes the glossopharyngeal nerve, and they have sometimes dramatic response to it. Now, the problem with glossopharyngeal neurology, we don't have good studies, so we don't know how to implement the use of MRIs and in this. So if you have a suspicion of his tumor, so you'll probably order. I mean, if the patient, I have a patient with glossopharyngeal neuralgia in my clinic, I will definitely go with the imaging studies. And the management is pretty much the same as for trigeminal neuralgia, where you can use carbamazepine and also basically all anticonvulsants. And surgical treatment is pretty much similar to the trigeminal neuralgia. The only problem with the surgical treatment with this in this condition is that because of the nerve itself, you can have sometimes side effects, which are usually not associated with trigeminal nerve. It could be dysphagia, problems with the voice, and persistent coughing, inability to speak loudly. So it's challenging. So you don't know for sure if you want to send a patient for this surgery. And the last we're going to talk about is postherpetic neuralgia, and again, it's it's a pain by definition which develops after the acute phase of herpes zoster infection and persists for more than 6 months. Now, this has been controversial because Dr. Portner, for example, goes with 1 month, I think, and some people go with 3 months. Sometimes you go, if you want to be more conservative, you'll call it 6 months. And most of the studies they do on postherpetic neuralgia, they use the 6-month definition. Now, it's the pain restricted distribution affected cranial nerves, and pain persists for more than 6 months. And we have a couple of these patients in PAC we've been treating with capsaicin topical cream, so with some good relief. Now, again, it has the quality of neuropathic pain. It's paroxysmal, and it can be sometimes elicited by mechanical stimulation. And in majority of cases, as we see it in the clinics, it involves V1 distribution, the postherpetic neuralgia. So what happens is that they can have, usually what they do is they can have those paroxysms of pain, but they can also have dull pain in the background. Now the outcomes, this is important to know about postherpetic neuralgias in general, also of those which occur on the torso. What happens is they actually are self-limiting. So 25% have good outcome without any therapy, and it actually goes down, the pain. But in the beginning, it can be such an excruciating pain, so they needed medical attention, needed treatment. And the guidelines, again, it's anticonvulsant, and here, this is the old slide. It shows topical capsaicin. Now we have topical capsaicin 8%, which you can use for postherpetic neuralgia in the face. It's off-label, but we do use it because for those refractory cases, we've been using it, and it's been effective for a couple of patients we had in PAC. And this is a typical facial pain, which is basically a patient comes and presents with a daily pain. Could be one side, could be both sides. It's kind of poorly localized, and it's usually not associated with sensory loss. There is usually a depression or some sort of deafferentation associated injury or phantom tooth pain, those kind of things. And our patient, for example, we injected with Botox the other day. She has bilateral pains in her jaws, and she feels like they are basically like TMJ kind of, but it's really not TMJ. She doesn't have click and all the other symptoms. And differential for the typical facial pain is, of course, the temporomandibular disorder, dental pain, sinusitis. You need to rule out that it's sort of diagnosis of exclusion again. And this is how they usually present: the pain in the jaws, sometimes in the nose, like a sinus kind of pains. Okay, and the guidelines. Now, these patients are a little bit tricky because you need to use more like a multidisciplinary approach because of the comorbidities, and then there you will basically consider, psychologists, neurologists, ENT, and dentists to follow these patients. And Again, drug of choice is sometimes SSRIs because of depression, comorbid depression, or TCAs. But I find that anticonvulsants can also have mood stabilizing effect and also good pain relief. So you can use that as well. For example, that patient we treated, she's on Trileptal with some response, and also injections. And again, guidelines, remember effective communications, talk to the patient, and it's very important to address the comorbidities. Okay, that was the lecture. Do you have any questions?